Good afternoon. My name is Angel Solar, and I will be presenting my capstone course project titled Minority Community Owned Initiatives. Health inequities continue to impact many urban communities, as well as how community empowerment can create many sustainable improvements within the population's health outcomes. Introduction. Our mission is achieving nutritional health equity for Black and Hispanic families within urban food deserts, as through the use of community-owned approach. Given how there's a lot of relevance, how it's over $451 billion of loss of when it comes to due to health inequities within racial and ethnic groups in the U.S. And considering how over 40% of the U.S. population identifies as some sort of minority group, it's interesting how, despite the rates being this high, they still face a disproportionate amount of barriers and social determinants of health. Um, um, so instead of focusing on a top-down approach where professionals make all the decisions, we wanted to move towards a community-owned model, allowing for the members of the community that are already actively involved to and have been observing the problems and identifying them. They can set their own priorities and lead in the solutions, which is especially important when it comes to racial and ethnic health disparities due to how many billions of dollars it costs the U.S. When these health inequities disproportionately affect. Uh, the biggest issue would be food security. Using the example of COVID-19, we see how in Black and Hispanic households, they experience a much higher, they experience much higher levels of food insecurity compared to white households. So these households tend to have higher levels of diabetes and cardiovascular diseases, and of course that worsens COVID-19 outcomes. These statistics also do a great job at showing how unequal access to healthy food isn't just about like nutrition within itself, but rather it directly correlates to chronic illness, to overall health, and of course even survival and the quality of experiences that happen during public healthcare emergencies. And of course, food insecurity doesn't just happen overnight, nor does it happen in isolation. So it's very closely interconnected with other social determinants of health, which would include, education, health access, health history, your background, your income, your access to technology, where you live in the population, how rural your location is, the geography of it all. Interestingly enough, lower grades of graduation lead to lower paying jobs. And that makes nutritious food more expensive, more hard, like it's more difficult to afford it. And of course, with limited internet access, there's like smaller opportunities for health education and just other telehealth services as well. And these together create these barriers create a cycle where health inequities continue throughout generations. They're just passed down unless we tackle it at the root. And doing that through a project framework, which would um, mm, So I use the Ottawa Charter for Health Promotion along the World Health Organization's community engagement framework. Instead of simply focusing on informing communities about like healthy behaviors, like preaching at them, we wanted to encourage the residents to become leaders when it comes to the decision making process in general. So this would include transforming vacant empty spaces to into like community gardens, and advocating for local nutritional policies that would be very beneficial to our communities. With the ultimate goal, of course, to empower said communities to develop solutions that reflect their own cultural values and priorities. And with this project, we specifically used a mixed method approach, um, and the research design, because we need more than just quantitative and qualitative data. We need both of or qualitative data. We need both of them combined together. Numbers alone don't tell a whole story, so it's very useful to use as all the research tools that we have at our disposal. So the quantitative data would help when it comes to identifying relationships between food access and outcomes, like the HbA1c levels, while qualitative methods would help with focus groups, and even using tools like Photo Voice allows residents to share, their own experiences. And using both of these approaches together can create a more complex and in-depth, a fuller, more nuanced understanding of the challenges that a community faces, as well as helping in the solutions. And we do this all while still maintaining an evidence-based approach and being culturally appropriate. So then, when it comes to our expected outcomes, we don't simply go down the route of, oh, just give everyone more healthy food. We want to focus more on initiatives that strengthen community relationships and building trust between residents and healthcare organizations. So by using the participatory action research, we allow community members to become our partners, instead of just passive recipients of healthcare services, allowing for a more meaningful and sustainable outcome and improvements over time. So to conclude, we are very much a strong advocate of how healthcare should be recognized as a basic fundamental human right, and not just as a privilege. And because of that, we also need to acknowledge social determinants and disparities within healthcare, education, employment, food access, everything that can be improved through collaboration and empowerment between healthcare professionals and the communities that we are here to serve. And that's the best way to create lasting change in the communities and the populations that we serve, and allowing them to be empowered enough to shape their own future. So to conclude, I'll leave you with one final question. So what's one action that you can take in your future practice to get closer to working with health inequity? These are my references. And if you have any questions, you are free to reach out. Thank you very much. Have a great day.